midbrain, then to the pons, and then via the medulla oblongata, they're going to produce medullary pyramids over there. And then the pyramidal decussation crossing over going to take place. And then there is production of lateral cross and ventricular uncrossed white matter over there in the spinal cord, leading to anterior horn of spinal cord through a interconnection and alpha motor neuron of opposite side they are being produced. So it is very important that we should be knowing about the corticospinal tract. Now, corticospinal tract, or the pyramidal system, that is direct activation pathway. Its function is to control primarily distal muscles, which are finely controlling the scaled movements of thumb and fingers on the opposite side. For example, painting, writing, picking up of a small object, etc. The pyramidal tracts, they are lateral corticospinal tracts, which are the crossed fibers. We have the ventral corticospinal tracts, which are uncrossed fibers. You can see from the motor cortex, they are going to pass through the posterior limb of internal capsule and then going to pass through the midbrain, going to pass through the pons in the form of longitudinal fascicles, and then they're going to pass through the medulla oblongata, and over there the decussation is going to take place, and ultimately some of the fibers they're going to cross to opposite sides, some of them they're not going to cross, and so going to lead to formation of ventral corticospinal tract and lateral corticospinal tract. So we have to know what are the corticospinal tracts, and you are supposed to draw and label them. The corticospinal tracts originates in the precentral gyrus in the internal capsule. Most fibers they decussate in pyramids and they descend in the lateral white matter of the spinal cord, that is the lateral division of the tract, which are monosynaptic connections with spinal motor neurons. The ventral division remains uncrossed and the spinal cord axons they terminate on spinal interneurons antecedent to motor neurons. You can see that pyramidal tract that is composed of the large myelinated fibers, which are 3%, and the smaller fibers they are 97%. So the large myelinated fibers, they are having the diameter of 16 micrometers. They are rapid to discharge at the rate of 70 meters per second. Over here, they are going to give rise to tonic signals, the smaller fibers. The types of motor activities, they can be classified into 3 movements. The first one is the voluntary movements, then we have reflex movements, and then there is rhythmic motor activity. Motor system includes the tracts like corticospinal, which are skillful voluntary movement pyramidal, then corticobulbar and bulbospinal, extrapyramidal. Then there is presence of basal ganglia, which are the regulators, then cerebellum, which are again the regulators of motor system. Now, overview of motor system, you can see that the cerebral cortex is going to give rise to the corticospinal tracts. Then the fibers, they are going to go to the thalamus, to ganglia, again from cerebellum. The impulses they are coming, which are the regulating, having regulator functions. And so this is how the whole motor system is working. Now, what are the components of motor neurons? Now, what are the components of motor neurons? There are upper motor neurons and there are lower motor neurons. Upper motor neurons, they are corticospinal and corticobulbar, starting from motor cortex, and they are going to end in the cranial nerve nucleus, they are corticobulbar, anterior horn of spinal cord in opposite side, which are corticospinal tracts. Then there is presence of lower motor neurons starting from anterior horn of spinal cord and ends in appropriate muscles of the same side, all peripheral motor nerves. The pathophysiological responses to damage to lower and upper motor neurons, they are very distinctive. Now, one of the very important questions frequently asked, the difference between upper motor neuron lesion and lower motor neuron lesion, hemiplegia, paraplegia. Now the differences they are, in upper motor neuron lesion, we are going to have the muscle group affected diffusely and never individually. In the lower lesion, the individual muscle may be affected. In upper motor neuron lesion, there is increased muscle tone, whereas this muscle tone decreases or disappeared if there is lower motor neuron lesion. Muscle atrophy is slight and due to disuse of muscle in case of upper motor neuron lesion, whereas muscle atrophy is quite high in case of low motor neuron lesion. The spasticity, the tonicity is quite high over there in the upper motor neuron lesion, and later on over there in case of low motor neuron lesion, there is no hypertonic condition, rather the muscles they are flaccid. Then the tendon stretch reflexes, they are lost first and later they are exaggerated, whereas the tendon reflexes, they are absent depending upon the site of lower motor neuron destruction. The clonus is present in upper motor neuron lesion and absent in the other condition. The plantar reflex of extensor type like Babinski's sign is positive here, whereas the plantar reflex if present is of normal flexor type. And it is extensor type over there in the upper motor neuron lesion. So you can say that Babinski's sign is negative in low motor neuron lesion. No fascicular twitchings they are there, whereas the fasciculations are there in condition of low motor neuron lesion. Now, one of the important scenarios which are being given in exams is hemiplegia. Now, what is it? Hemiplegia is the upper motor neuron paralysis affecting one side of the body. If the muscles are not paralyzed but are weakened, the condition is known as hemiparesis. It presents as weakness either permanent or transient of limbs of one side, often with loss or disturbance of speech. It is due to the damage to the blood supply of the internal capsule, that is, rupture, thrombosis, or embolism of the lenticulostriate artery, a branch of middle cerebral artery, can lead to this condition. Due to damage to the blood supply of internal capsule, damage to corticospinal tracts together with closely associated extracorticospinal fibers can lead to hemiplegia. At the level of internal capsule, the corticospinal fibers are intermingled with many other fibers to end in globus pallidus, red nucleus, and reticular formation, also fibers ascending from the thalamus. Now, what are the clinical features? Clinical features depending on the site and extent of infarction. They are actually depends upon the site and extent of area of blockage of blood supply or damage of the brain. So obstruction of carotid circulation, middle cerebral artery obstruction causing infarction of internal capsule, which leads to following deficits of the opposite side of the lesion, which are there is hemiplegia of face, arms and legs, hemisensory loss, there is bilateral symmetrical loss of vision in one half of visual fields, there is aphasia, which is loss of speech if dominant hemisphere is involved. Dominant hemisphere is left in right-handed persons. Anterior cerebral obstruction. Stroke is uncommon because the alveoli from extracranial arteries are entering the large caliber middle cerebral artery, which receives the large bulk of cerebral blood flow. The stroke develops with the following features. There is hemiparesis and cortical sensory loss in the legs, arms, and face. There is urinary incontinence due to failure to inhibit the reflex bladder contraction. If there is obstruction of cerebellar and basilar arteries, it produces the sign and symptoms of brainstem dysfunction, which are ataxia, diplopia, double vision, nystagmus, oscillatory movements of eyeball, dysarthria, difficulty in talking, dysphagia, difficulty in eating, cranial nerve palsy, bilateral sensory symptoms, loss of consciousness, sensory and motor deficits are crossed, that is, affecting face on one side and limbs on the other side of the body. Now there is the stages of hemiplegia. First is the stage of shock. Patients, they become drowsy or comatose when they develop large infarct or cerebral edema and the function of the other hemisphere or brainstem is disturbed. Initially, the muscles of opposite side, they are paralyzed and may be flaccid and reflexes can be depressed despite an extensor plantar response due to spinal shock. The paralysis affects most severely muscles of hand and arms. Leg muscles are less affected. In cranial musculature only, the muscles of lower face and tongue are involved. Bilateral movements, that is jaws, pharynx, larynx, thorax, and abdomen are retained. Emotional movements of lower face like smiling and crying are also affected by a cortical or capsular lesion. Sudden inactivity of higher centers, complete paralysis and loss of reflex activity that is there. Then there is a stage of recovery. 2 to 3 weeks they are needed to reach this stage of recovery. A paralyzed arm may move suddenly, showing the onset of this stage. Now the clinical features. In the posture, there is hypertonia. Upper limb is abducted at the shoulder and semi-flexed at the elbow. Forearms are pronated and wrist and fingers are flexed. Muscles, they show clasp knife spasticity. Muscles increased, resistance to the lengthening. Voluntary control of muscles are reduced or lost. There is slight muscle wasting. Then there is presence of hemiplegic gait. Hemiplegic gait, the leg is rigid and does not swing freely at the knee and hip. It rotates outward and undergoes semicircle, foot scrapes along the floor. This is the hemiplegic gait. The deep reflexes, which are tendon or phasic stretch reflexes, there is increased muscle tone, exaggerated knee jerk and other tendon reflexes. Ankle clonus is present. The combination of muscle hypertonia, hyperactive tendon reflexes and clonus is termed as spasticity. Superficial reflexes like abdominal reflex, cremasteric reflex, they are lost. The normal plantar flexor reflexes are being replaced by extensor plantar reflex or Babinski's sign. In hemiplegia, big toe is dorsiflexed and other toes are fanning out. Then, the late stage.